Good afternoon, everyone, and thank you for allowing me to participate from remote to present these presentations. Here are my disclosure. First, we should recognize that LDL is a key player in the development of atherosclerosis. Know that LDL receptors are in a serious bind, and they are in the liver, essential to removing plasma LDL cholesterol. What was discovered that there is an endogenous protein called PCSK9 that binds to the LDL receptors and promotes their degradation, leading to increasing plasma LDL cholesterol. The PCSK9 inhibitors is a monoclonal antibody that bind PCSK9, increase the number of free LDL receptors, so lower the overall LDL. The first question that I was asked, can decreasing LDL cholesterol sharply produce plaque regression in the coronary arteries? The Glackov trial was designed to address this issue. It was a 968 patients that were randomized to statin monotherapy versus statin plus monthly subcutaneously evolocumab 420 milligram. Those patients underwent baseline and follow-up IVUS imaging. Indeed, you can tell that there was a nice reduction of the LDL cholesterol in the evolocumab statin group up to 29 milligram per deciliter. Primary endpoint has been met with reduction that overall percent atheroma volume nearly 1% in the statin evolocumab group versus slightly increase in the statin monotherapy. When we look at the secondary endpoint, total atheroma volume, it was nearly 5.8 versus 0.9. It was highly statistically significant in favor of the statin and evolocumab. Then look on a specific group of LDL cholesterol less than 70 milligram per deciliter. In this group, the LDL cholesterol dropped even further to 15 milligram per deciliter. And when we're looking on the percent atheroma volume, it was about minus 1.97 versus minus 0.35 in the statin monotherapy. When we're looking on the fraction showing regression, it was noted in 81.2% of the patients with statin and evolocumab versus 48% in the statin monotherapy alone. The question now is, what about carotid arteries? And we learned in the last ESC meeting that rapid carotid plaques reversal of PCSK9 inhibitors is shown when added to statins and fish oil in high-risk cardiovascular patients. In this study, the average LDL cholesterol was 75 and the triglycerides was 102 in the control group. In the LDL cholesterol in the trio group was 22 and the triglycerides was 92. There was 20% to 65% plaque reversal, which was occurred after 6 months of the evolocumab therapy in 37 patients. And there was minus 28 progression to 0 reversal in 10 patients who took the evolocumab only for 3 months. One patient had 50% left common carotid stenosis that was reversed down to 2.5 by CIMT plaques after only 3 months of evolocumab. So what do we know about the goal of LDL cholesterol? The Fourier trial showed us that the overall LDL cholesterol was reduced by 59%, and it was consistent through the duration of the trial. It also showed us that it was associated with reduction of CV outcomes with 15% broad primary endpoint reduction, 20% of reduction of CV death, MI, or stroke, consistent benefit including in those with high-intensity statin and low LDL cholesterol. 25% reduction was shown in CV death, MI, stroke after the first year, and there were long-term benefits consistent with statins per millimole of a liter of reduction of LDL cholesterol. We also showed that this was safe and very well tolerated, and there were similar events of AEs between the two groups. One important information is to look at the 8 quartiles, 4 of the placebo and 4 of the evolocumab, that actually show us in a very linear fashion that the lower is better in associated with less cardiovascular death, MI, or stroke, regardless to the treatment arm. So if we summarize and conclude, we can tell that LDL cholesterol can now be reduced to unprecedented low levels with statin and PCSK9. LDL cholesterol reduction is associated with coronary and carotid plaque regression. A strong progressive relationship of achieved LDL cholesterol and CV events seen down to LDL of less than 10 milligram per deciliter. There is no excess in safety events with very low achieved LDL cholesterol of less than 0.5 millimole at 2.2 years. And a combination of statins, PCSK9, and EPA is effective in plaque regression in the carotid. These data suggest that we should target considerably lower LDL cholesterol than in currently recommended guidelines of our patients with atherosclerotic CV disease. Thank you very much for your attention, and I'd like to invite all of you to participate in CRT 2018, in which we will have a half a day just dedicated to this topic, and the keynote will be given by our past president, President Barack Obama. Thank you very much.